Bismillah ar-Rahman ar-Rahim. Good evening, ladies and gentlemen, and welcome back to our SSBD regular webinar time of our scientific activity after Ramadan and exams and schools. Would like to be back to our activities and series of webinar, and we're starting today for an attractive topic with multiple myeloma. And our title today is How I Treat Multiple Myeloma, especially in the highlight of the new EHA updates. So over the next 1 hour, we'll have two eminent speakers with special experience in myeloma, and we'll have two talks. Each talk will be 25 minutes, and then we'll have a panel discussion, and we'll receive a question and answer. Just to let you know that this webinar is accredited by CME Awards through Saudi Council for Health Specialties. And it is recorded, and you can reach to this webinar through our social media channel for SSBD. Please submit your question and answer through the Q&A icons, and we'll respond at the Q&A session after the presentation. I would like to take this opportunity to thank Sanofi for sponsoring this webinar and for their continuous support and participation in our continuous activity and educational activity specifically. So our first speaker for today is Dr. Majid Al-Ahmadi. Dr. Majid is a consultant adult hematology and bone marrow transplant at Princess Noura Oncology Center, King Abdulaziz Medical City in Western Region, Jeddah. Dr. Majid has a special interest in myeloma and lymphoid malignancies. And Dr. Majid will talk about upfront or risk-based therapy for newly diagnosed multiple myeloma in 2020 region time. So, and we'll highlight on what's new in the EHA presentation. Please, Dr. Majid.
Bismillah ar-Rahim. Assalamu alaikum and good evening, everyone. First of all, I would like to thank the SSBD for these very interesting and excellent series of webinar, and I would like to thank them for inviting me. And I'm thanking our chairman today, Dr. Amal Bihani, for the nice introduction. So I'm gonna talk about the therapy of newly diagnosed myeloma in 2022. I will try not to repeat what's been presented before. I'm gonna try to bring some of the new updates from the most recent EHA and some other interesting trials, and I hope that will be useful for everyone. So I think you have seen this diagram, and this is basically represent clearly what's happening with every myeloma patient. They start with a very benign indolent disease, MGUS smoldering, and then they have the active myeloma. They get treated, and they are very different in terms of their response. And that's sometimes puzzling for every myeloma treating physician. And sometimes we wonder about how should we properly risk stratify these patients, because some of the patients, based on the current data, they are labeled as a standard risk, although in behavior-wise, they don't behave like standard risk, meaning that we don't know everything, and we still have lots of things to learn about this disease. But I think everyone would agree that the longest remission for every myeloma patient is the first remission. And that tells you how important the initial therapy is, because this is the longest remission, and the patient would be at the best situation, and of course he will be younger. As the time goes, nothing will happen except he is becoming more older. So that's why we have to take the opportunity at the beginning and hit the disease hard, but also we have to be careful about toxicities and not causing problem for the patient. And one of the challenges with myeloma, as the time goes, the patient becomes more refractory. Okay, and once we're reaching to the third and fourth line, that's where the trouble will start. So, and that shows you how poor the survival is in patients who are double or triple or quadruple refractory. Their survival is just few months. And this is the usual sad side of the story. So that's why I'm saying we have to take the opportunity at the beginning and treat hard. But also we have to be careful, as I mentioned, and we have to balance with the toxicities. So how aggressive we have to go? All the current data show that the deeper the response, the better the outcomes. And this actually diagram from the IFM 2009 showed that patients who achieved MRD negativity, regardless which therapy they received, transplant or non-transplant, they did better. So now all the data showing the MRD is a very attractive target, and people who achieve MRD, they do better. So this is the journey of transplant eligible myeloma patients: induction transplant, maybe second transplant, consolidation maybe, and maintenance. So now the things that I will try to answer during my talk, the best way of risk stratification, what is the best induction, and especially based on the risk status of the patient, is transplant still needed in 2022, and what's the best maintenance for these patients and for how long? So we are all familiar with the RISS, the Revised International Score System, but as I mentioned to you, it doesn't tell us the whole truth, because some of the patients are labeled as standard risk, but they don't behave as so. And the Harmony project from the EMN looked into more variable this time, and they are trying to risk stratify patients in a better way. And they came with this proposal looking at these variables, ISS stage 2 or 3, and based on that, the patient will get either 1 score or 1.5 score. 17p deletion will give the patient 1 score, high LDH 1 score, translocation 414 1 score, and 1Q amplification 0.5. So you calculate the risk of the patient, and based on the score, it will be labeled from either low to high, as you can see here. And that shows you the difference in terms of PFS and overall survival between the different groups. And I think that should be now the newer way of risk stratification rather than using the old RISS. So this is actually published just a few weeks ago. So in terms of induction, how can we improve induction therapy in myeloma patients? So induction, it has to be fast in responses, has to be deep, well tolerated, available, affordable, and does not interfere with the stem cell collection. So you're all familiar with the IFM 2009, which looked at the use of induction as a VRD. Then the patient were randomized to either receive transplant or no transplant, and then to go with the maintenance after either consolidation if no patient did not receive transplant. And it showed the good results, meaning that this induction regimen is quite good. And now it is becoming the standard of care, I think, almost all the kingdom and in many places in the world. But can we do better than that? So the addition of monoclonal antibody is becoming now a more attractive option, using a different PI like carfilzomib, combination of both carfilzomib and monoclonal antibody, or using other novel agents, as shown in some phase 1 trials so far. So the Griffin, I think you are familiar with this. It's a phase 2, so you need to remember that this is a phase 2 trial, not a phase 3. looked at the use of VRD with either DARA or no DARA, and then transplant was part of the journey. And in this trial, as has been reported before, it showed improvement in the PFS in the daratumumab arm with deeper response and better progression-free survival. The same thing was shown by the Cassiopeia, so the addition of daratumumab to a backbone of VTD resulted in a better response in terms of a deeper response, as well as shown here by the MRD negativity and also by the PFS results. So on the other hand, the other monoclonal antibody, the istoximab, was studied by the German Hodgkin lymphoma group in the HD7 trial. So this is a phase 3 trial, randomized the patient to receive either RVD versus ESA RVD. Then everyone will go for transplant, then maintenance either ESA R or R alone for 3 years or until progression. So the primary endpoint of this trial was the MRD negativity, and it was met. But still, we don't have the results of the PFS. I think it will be released soon, I would guess, during the next ASH. So that's also another promising regimen. What about use of carfilzomib in the upfront setting instead of bortezomib? So now for high-risk patients in, for example, in Mayo Clinic, they put that as part of their MSMART guidelines. But what about the non-high-risk patients? So in the Endurance trial, they looked into that. The patients were randomized to receive either VRD or KRD. And unfortunately, the study was negative, so they did not show significant improvement in the PFS, but there was more toxicity with the use of KRD. So how about if we are combining both KRD and monoclonal antibody? So the master trial looked into that with DARA KRD. This is MRD based regimen. So all the patients would receive KRD ×4 and then will go for transplant. And then the MRD surveillance would be would start. And if the patient is MRD negative at any point, would come off the trial. So transplant, then for consultation with DARA KRD. If still MRD positive, another 4. If still positive, you go for len maintenance. The interesting thing about this trial that the patients were included are actually of a high risk. So you can see here the number of the RISS3 and about 21% of the patients were 17p deleted. There was some safety issues here. So there was some mortalities related to pneumonias and some other unknown or unpublished causes. But, you know, I have to say this is a more of aggressive protocol. So you have to be careful before you use it. And I think anyone who's not young and fit might have issue tolerating such aggressive regimen. But despite that, you can see here the response was quite impressive with a deep VGPR, and also the MRD results were quite good. This even in patients who had 2 or plus high risk cytogenetic abnormalities like 17p or 414. So even for these patients, they did well, meaning that this is one of the protocols that can be used for that group of patients. The progression-free survival was also great in this trial. So as I mentioned to you, this might be of a promise in the future. So the other question, do we still need transplant or not? So based on the IFM 2009, the transplant resulted in improvement of the progression-free survival, but still there was no survival benefit as of yet. So in the most recent EHA meeting, Another trial came with the same flavor, but the good thing, it actually made our belief in transplant stronger. So the determination study, it has almost a similar kind of protocol. So RVD as an induction, and then the patient would be randomized to either to go for transplant or to get more cycles of VRD and also consolidation with VRD. So you can see here the number, and then everyone will go on our maintenance. So almost more or less very close from the protocol of the IFM. We can see here the patient characteristic in this trial. So it's included like the usual kind of mixture that we would see in our patients. So the data here was consistent with what we know from the IFM 2009, with improvement of the PFS. So at 5-year interval, PFS in the transplant arm was 55.6 versus 41.5 in the non-transplant arm. And you can see here also the difference in the time to progression and the event-free survival. So favoring the transplant arm. In terms of the patient, the subgroup analysis, some races had less effect with the transplant, like Black or African Americans. Also, patients who are overweight, the transplant benefit was not that clear, in contrast to patients who are of BMI less than 25. And despite the high risk group, also patients with 17p had less improvement, but still they were better in the transplant arm rather than the non-transplant. In terms of this response, there was no difference in the overall response rate. Why is that? We are still, so the comparable arm is still, it's a good option. So VRD only is not that bad. So you would expect this results that even VRD alone will give you a great overall response. So the duration of response were still in a favor of transplant arm. So and as well as the MRD, so patients who underwent transplant had a deeper response with MRD negativity of more than half, so 54.4 versus only 40% in the non-transplant arm. As we expect, there was no survival benefit between the two arms. It's still early to see such a thing, but you know, the good thing, there was no survival disadvantage in both arms. So basically, as a conclusion from the IFM and determination trial, now we are feeling more still, we are feeling comfortable that transplant is the way to go up to 2022. So what about the high risk myeloma patients, difficult to treat group? So this trial, also by the German group, the GMMG concept, they included patients with high risk myeloma, RISS 2 and 3 with high risk abnormalities in the cytogenetics, and they included both actually transplant eligible and transplant non-eligible. So they had more patients who are eligible rather transplant eligible. So if the patient is transplant eligible, they would go for ESA KRD for 6 cycles, and transplant, then consolidation with another 4 cycles of ESA KRD. Then they will go on an intense maintenance, which is ESA KR, where patients will, if they are non-transplant eligible, will get 8, then 4, and then the same kind of maintenance. So the promising results that, you know, despite we know these group of patients are difficult to treat and they don't do well, but despite that, their PFS is quite good. And you can see here how the curve here plateau And at almost 3 years or more than 2 years, still the median of the PFS was not reached. And we can see here there is the results. Also, the depth of the response was quite good. So overall response rate was 100% in that study cohort, with 61% MRD negative. So this is also a very promising results. The French group, they looked into the same kind of concept. So looking at patients who are high risk transplant eligible, and this is from the most recent EHA meeting in the IFM 2009 phase 2 trial. So it's a single arm here. So the patient who are newly diagnosed, transplant eligible, and they had a high risk cytogenetics, making them as a high risk. They received an induction of DARA KRD for 6 cycles. Then we'll go for stem cell collection and transplant, consolidation by another 4 cycles of KRD, then second transplant, and then maintenance with DARA-LIN. So very intense protocol, as you can see here. They are aiming for tandem transplant from the beginning. So they had to actually amend their protocol. And instead of doing the stem cell collection after 6 cycles, they amended this to get the stem cell collection after 3 cycles. So 3 collection, then another 3, then first transplant, then 4 KRD, DARA KRD, and then second transplant, then maintenance. So you can see here that all of the patients were included. They had high risk cytogenetics. Almost half of them were 17p. So we are talking about high risk patients. About 25% of the patients, they discontinued the study protocol because of variable reasons, progressive disease, or inability to tolerate the therapy. But also this study showed the promising results with overall response rate of 96%, with VGPR or better of 91%, with MRD negativity also comparable to the previous trial at 62%. And we can see here the same thing. So at 18 months, we are still seeing the curve of the PFS and the survival plateau. And this is actually quite good and encouraging results. So what about maintenance? How can we improve maintenance in that group of patients? We all know now that the French and the American group looked into that, and the myeloma 11, the American group, they found there is improvement in the PFS, but also there was survival advantage. The other trial did not show that survival advantage, but now, of course, no one will argue about this. Maintenance is highly recommended in patients who are newly diagnosed myeloma who are transplant eligible. Is there any way to improve our maintenance regimen? So maybe addition of monoclonal antibody along with the lenalidomide would result in improvement. And as we see from the Griffin trial, that incorporation of monoclonal antibody with IMiD resulted in a deeper responses and also very encouraging MRD results. The same finding were also in the Cassiopeia trial with good MRD negativity as a sustained MRD in patients who are on DARA maintenance. But most of these results were shown in patients who did not receive DARA as part of their induction, as was shown here in this slide. So another trial was done by the Greek group in cooperation with Chicago University, the Atlas trial. So it's a phase 3 randomized trial looking at improvement of the maintenance therapy in post-transplant setting. So patients who are transplant eligible, newly diagnosed, were included after less than 100 days after transplant, and less than 1 year from the time of the diagnosis, and were randomized to receive either KRD as maintenance versus LEN as maintenance. And basically, if the patient achieved MRD negativity, they can discontinue the KD after receiving 6 cycles and to continue with LEN alone. But if they are still MRD positive, they will continue on the triplet as maintenance. And basically, they were doing that for 3 years, looking for these primary endpoint, mainly the PFS. So the studies met their primary outcomes. So patients who received this intense maintenance therapy, I would say, they had improvement in their PFS. So the median PFS in the KRD arm was almost 60 months, where it was 41 months in the LEN arm, with a hazard ratio of 0.56, so meaning that KRD will decrease risk of progression by 39% with significant p-value. There was no survival benefit, as we can see here, which is expected in such a patient cohort. Toxicity-wise, there was, of course, there was increased toxicity in the KRD arm, but there was no alarm of safety concern in form of grade 3 or more toxicities, as we can see here between the 2 groups. So what's next in the future? So basically now we need what we need to do now actually is to adapt our therapy based on the patient response. So instead of applying the same thing to everyone, we should actually adapt our therapy based on the patient response. Not everyone might need to go for transplant. Not everyone might need to go for very aggressive maintenance therapy. So the master trial tried to look into that with MRD adapted approach. So we will be happy to hear an answer from this trial. And also the Perseus trial, the EMN17, looking at the same kind of question. So addition of daratumumab and VRD. So this is the phase 3 trial, not like the Griffin was phase 2. So this is phase 3 trial. And so they are looking at the effect of DARA VRD in patients who are newly diagnosed myeloma. And also they are risk adapting therapy based on the MRD status, as you can see here. So not everyone will get the same maintenance in terms of duration, because we always ask that question: what's the best duration for therapy? Should we continue maintenance until disease progression? Should we stick to 2 years? Should we stick to 3 years? To tell you the truth, now in most of Europe, they are using maintenance for a minimum 3 years, as long as the patient is tolerating. Most of the experts now, they are thinking that no, we should go back to until disease progression. But you know, these kind of protocol, this will help answering that question in a better way. So for the transplant ineligible towards same to what has been published before, the addition of DARA also result in improvement in these patients' outcomes, as in the LCON trial and also in the Maya trial, which showed a very promising results with the PFS of around of more than 60 months in patients who are transplant ineligible. So now this is becoming more of a standard of care, I would say, as long as the patient is tolerating. But you have to be careful. Also, this protocol might be difficult to be tolerated for elderly, frail patients. This is something you would consider for transplant ineligible but fit. And remember to apply the IMWG fitness score. So as a conclusion, novel agents combination has resulted in significant improvement in the outcomes in newly diagnosed multiple myeloma. Combination of novel agents plus monoclonal antibody up front might be the new standard of care, but we need more follow-up and more data about this. And I think the time will tell us more. So response adapted therapy might be the future for myeloma and not one size fits everyone. I hope that was clear for you, and thank you so much.
Thank you, Majid, for the excellent highlights and excellent overview. So we'll leave the question at the end of the session with the panel discussion. So please submit your question to the Q&A icons and we'll respond at the end of the session. So coming to the next talk, next speaker is Dr. Fahad Al-Sharif. Dr. Fahad Al-Sharif is a very well-known senior consultant from King Faisal Specialist Hospital, Riyadh. Dr. Fahad is the director of the transplant program for myeloma and myeloma program in King Faisal Specialist Hospital. Dr. Sharif, sequencing therapy in relapse refractory multiple myeloma. Please, Dr. Sharif.
بسم الله الرحمن الرحيم وبه نستعين وصلى الله على سيدنا محمد. Thank you very much, Dr. Amel, for this nice introduction. And I would like to thank Sanofi for the participation in this very good meeting. And also I would like to thank for blood disorders or diseases for their continuous education, not only for doctors, clinicians, but also for the society. We are proud of such a society that is present in the kingdom. I'm going to talk about some choosing therapy in relapsed refractory multiple myeloma. Thank you, Dr. Majid. You showed this slide before or similar slide. However, what can I say? Really, the treatment in general of multiple myeloma dramatically changed due to the introduction of new drugs and combinations either in the newly diagnosed patient or in relapsed refractory patient. And right now, at least, we do have 11 classes of therapeutic agents. For example, selective inhibitor of nuclear export, drug conjugate, monoclonal antibody, bispecific agent, and so on and so forth. From this slide, we can see, and as Dr. Majid mentioned, that the best probably response for the safe patient with multiple myeloma is during the first treatment, in which there will be a good response as well as a deepest response in the start. Subsequently, in the relapse, either first relapse or second relapse and subsequent relapses, there will be inferior responses, as well as the deep of the response. So I think we have to concentrate on the initial treatment, but we have to keep in mind about the side effect. Variable evolution dependent on individual risk factors, including genetic and phenotypic change, depth and duration of response to therapy, the resistance of a malignant multiple myeloma stem cell, and evolution of competing multiple myeloma clones are very important. In fact, eventual relapse with patient outcomes declining, as we explained before, with each subsequent relapse. And this is really showed when median progression-free survival and overall survival by treatment line from 2011 to 2017 showed really this is a fact. Really, the first line is the best response, then subsequently decreasing by the second, third, fourth, and fifth, not only for the progression-free survival, but also for overall survival. So the remission after the first treatment tends to be the longest and most durable. Why is that? We have to look carefully about the successive rounds of treatment. And because that patient and disease characteristic can worsen. For example, frailty will be increased with chronological and physiological age. Also, the number of comorbidities will be increased, and also decrease of the ability of the body to withstand treatment-related toxicity. There will be evolution of clones, and subsequently more cytogenetic abnormalities may increase. For example, nowadays we do have the problem of the resistant to specific drug. For example, lenalidomide refractory relapsed disease and refractory. So all of these factors can reduce the number of effective and/or tolerable treatment options available. If we shall look here with the lenalidomide refractory disease, it is really unfortunately have the poor prognosis and represent a high unmet medical need. For example, if you look here with patient with lenalidomide refractory or non-lenalidomide refractory, you can see the difference. In the first group, patient will have more renal insufficiency, more anemia, more hypercalcemia, bone disease, i.e. more disease burden. And if you look at the progression-free survival from start of second-line therapy, there is a remarkable difference between the lenalidomide refractory and non-lenalidomide refractory. In non-lenalidomide refractory, the median progression-free survival can reach to 19.4 months, while in lenalidomide refractory, only 7.5 months. So patients with lenalidomide refractory disease at first relapse experience shorter progression-free survival and have greater disease burden compared with patients not refractory to lenalidomide. If we look at this slide really about the attrition rates, it is really increasing from line 1 to line 2, line 3, and line 4. Not only in Europe, but also in the United States, as you can see here, whether those patients with transplantation or non-transplantation, still they will have really progressive and increasing attrition. So with every new line of treatment, there is about 15% to 57% of patients are lost. So why is that? Because, and at the same time, during that time, we have to think about many factors and to consider them really when we are going to think about how to treat this situation with relapsed refractory multiple myeloma. So a number of factors, for example, disease burden and biology, like cytogenetic risk, like plasma cell proliferation, stage of the disease, extramedullary disease, refractory disease, and bone disease. Also, host factors are very important regarding the age, frailty, and performance status, as well as comorbidities and organ function, cardiac and hepatic, especially if we are using some drug leading to cardiac abnormalities like carfilzomib. Patient preference is very important. We know that it is really a big burden for the patient to come to the infusion area and to receive the medications. Therapy-related factors are important because the previous therapies can lead to a number of problems, including refractoriness, depth of duration and response after prior line, treatment tolerability and toxicity, also important, as well as drug availability. Not all the centers, they do have all the medications available for multiple myeloma, especially those very expensive medication. So we have to consider all this. Difficult to treat patient profile also is important because elderly, and nowadays actually we are not transplanting patient up to 65. We are moving that number to 70 to 75, and some people that might go beyond that as long as the patient is fit for transplantation. So frailty will come up like that. Extramedullary disease as a complication, renal impairment, high-risk cytogenetic, and finally the treatment history in which there will be Revlimid refractory relapsed disease. So in a whole things that there is unmet needs in multiple myeloma include patients who are elderly, frail, renally impaired, as well as patients with high-risk cytogenetic extramedullary disease or lenalidomide refractory disease. What can we do for these relapsed refractory multiple myeloma? If we shall look really, there is an expansion of the treatment landscape, at least from 2017 to the present time, 2022. And in 2017, really, we do have only one combination, daratumumab, Revlimid, dexamethasone, and daratumumab, Velcade, dexamethasone, for those patients who are relapsing after one or more cycle therapy. On the other hand, even if the patient relapsed after 2 therapies, also still daratumumab can be used, but with a second generation of IMiDs like pomalidomide and dexa combination. Moving to that, really, there is a progressive improvement in the combination treatment for these patients. For example, if we shall look at 2021, we can find that daratumumab in combination with pomalidomide, dexamethasone can be used for those patients who are received 1 or more prior therapy. And not only that, but also other drug monoclonal antibodies like isatuximab in combination with carfilzomib, dexamethasone showed a very good response and have been used after 1 to 3 prior lines in the United States of America, or equal or more 1 prior therapies in Europe. And this is now approved for that. Again, for those patients who are relapsing after 2 therapies, after the treatment really, and they do have relapsed refractory multiple myeloma, new medications, for example, selective inhibitor of nuclear export, selinexor, even though it has a number of side effects, but it's an effective drug when it is combined with dexamethasone in this situation. And it has been used in those patients underwent 4 or more prior therapies and refractory to equal or more than 2 proteasome inhibitor, 2 or more IMiDs, and an anti-CD38 monoclonal antibodies and disease progression on last therapy. Also, daratumumab in combination with BD also can be used. And also nowadays, CAR T-cell also has been involved in the treatment, but in those patients who had 4 or more lines of therapy in the United States, but in Europe, 3 or more of the treatment. In 2022, we find that CAR T-cell using cilta-cel is really can be used. And during the EHA meeting recently, actually, it showed the updated cilta-cel information, showing us really a very good response as well as deep of the response. And it is very encouraging results, and probably this is going to be the lead of the treatment of multiple myeloma. We don't know so far, but who knows that there are new medications as well as this CAR T-cell therapy. Look at the guidelines. For example, 2022 NCCN guidelines for relapsed refractory multiple myeloma. They are recommending isatuximab in combination with pomalidomide, dexamethasone, and isatuximab in combination with carfilzomib, dexamethasone as preferred regimens. And previously treated multiple myeloma with 1 to 3 prior therapies and put it as category 1 recommendations. Preferred regimens, for example, carfilzomib, Revlimid, dexamethasone, or monoclonal antibody in form of daratumumab, Velcade, dexa, or daratumumab in combination with carfilzomib, dexa, or daratumumab in combination with Revlimid, Dexa. Also here, isatuximab has been included in combination with carfilzomib, dexamethasone, or with pomalidomide and dexamethasone. Also, pomalidomide in combination with Velcade and dexamethasone can do the job, as well as daratumumab in combination with pomalidomide, dexamethasone. Other recommended medications can do like PAD or like ERD, but as you know that some centers, they don't have enough medications available. So VD can do some result, however, or RD or BD, but however, it is going to be inferior to the triplet regimen in this situation. Late relapses, more than 3 prior therapies, no category 1 recommendations, and after more than 4 prior therapies, including anti-CD3, 38 monoclonal antibodies, proteasome inhibitor, and an IMiD. Nowadays, we can see that a new drug conjugate monoclonal antibodies like belamaf can be included, as well as the CAR T cell. Also, selinexor in combination with dexamethasone can add it in the guidelines. So, from the NCCN 2022 guidelines, we can say that isatuximab in combination with carfilzomib, dexamethasone, and isatuximab in combination with pomalidomide, dexa, can be used in category 1 recommendation based on high-level evidence. There is uniform in CCN consensus that the intervention is appropriate. What about International Myeloma Working Group 2021 guidelines for the relapsed refractory multiple myeloma? Also, give isatuximab in combination with pomalidomide, dexa, and isatuximab, carfilzomib, and dexamethasone, a grade 1A recommendation. And they divided into 2 groups, whether non-refractory to lenalidomide and refractory to lenalidomide. In case of not refractory to lenalidomide, they will give preferred option like monoclonal antibodies in form of daratumumab in combination with lenalidomide, dexa, or carfilzomib in combination with Revlimid and dexamethasone. Alternative can be used here like DPD or KD or DKD or isatuximab KD and others, as you can see in the slide. If daratumumab, isatuximab, or carfilzomib not available, this is really not good, but however, there is still an option. However, the response is going to be inferior. In refractory to lenalidomide, preferred options is really pomalidomide, which is immunomodulatory agent, second generation, in combination with Velcade and dexa, with daratumumab, carfilzomib, dexa, or isatuximab, carfilzomib, dexa combination. Alternative like daratumumab VD or KD. Other options, as you can see, it is mentioned here. Again, they mentioned that if daratumumab, isatuximab, or carfilzomib, or pomalidomide not available, we can go back and use the PCD, VD, VMP. However, I think the outcome will be inferior. In second relapse, preferred option, and first relapse options that have not been tried, like for example, isatuximab, pomalidomide, dexa, or daratumumab in combination with carfilzomib, dexa, or dara in combination with pomalidomide, dexa, or isatuximab in combination with carfilzomib, dexa, based on phase 3 trials data. High-level quality evidence for recommendation based on several high-quality studies with consistent result. Again, what about EHA, ISMO 2021 guidelines for relapsed refractory multiple myeloma? Also, they give ESA in combination with pomalidomide, dexa, and ESA in combination with carfilzomib Dixa, a grade 1A recommendation. And in the second line, they are putting really whether lenalidomide sensitive or lenalidomide refractory, Velcade sensitive or lenalidomide Velcade refractory. If it is sensitive, there are a lot of options, including isatuximab, carfilzomib, dexamethasone. But problem sometimes with Revlimid refractory situation, in which really pomalidomide, Velcade, dexamethasone can be used and effective. Daratumumab in combination with carfilzomib Dexa can be effective also. And isatuximab in combination with carfilzomib Dexa, or finally selinexor in combination with Velcade and dexamethasone. In relapse in Revlimid Velcade refractory, monoclonal antibodies, either daratumumab or isatuximab in combination with carfilzomib Dexa can be an option. Further, EHA ISMO guidance on the treatment of lenalidomide refractory, as we mentioned that PVD, DKD, or isatuximab carfilzomib Dexa, or selinexor VD and daratumumab VD are recommended options. However, if also bortezomib refractory, isatuximab carfilzomib Dexa can be used versus daratumumab carfilzomib Dexa, i.e. monoclonal antibodies in combination with second generation proteasome inhibitor and dexamethasone. In daratumumab exposed patient, pomalidomide in combination with Velcade Dexa can be used, or carfilzomib Dexa can be used, or selinexor VD can be used. In case of translocation 11-14, we have to consider then the Velcade dexamethasone combination. However, we have to keep in mind that venetoclax is not yet EMA approved. Also, we should not forget about clinical trials. Still is recommended at second or subsequent relapse. What about isatuximab? Isatuximab is a monoclonal antibody against CD38. It is a glycoprotein highly expressed on myeloma cells. It has a very good, really, modes of action. For example, Fc-dependent immune mechanisms, ADCC, CDC, and ADCP. Fc-independent direct apoptosis, and that can kill the myeloma cells directly. Inhibition of CD38, ectoenzyme activity, and also immunomodulation effect. So, accordingly, isatuximab is approved in relapsed refractory multiple myeloma in combination with pomalidomide and dexamethasone for the treatment of adult patients with relapsed and refractory multiple myeloma who have received at least 2 prior therapies, including lenalidomide and a proteasome inhibitor, and have demonstrated disease progression on the last therapy. Not only that, but also isatuximab is approved in combination with carfilzomib and dexamethasone for the treatment of adult patients with multiple myeloma who have received at least 1 prior therapy. So, what about the future? Still, trials are going on about isatuximab, and it is being investigated across the multiple myeloma treatment continuum. For example, in a symptomatic multiple myeloma, or what we are calling it as high-risk smoldering myeloma, now EHA trials going to be started, including RD versus RD isatuximab. In the symptomatic multiple myeloma, either newly diagnosed multiple myeloma, either stem cell transplant eligible or ineligible, both of them, there are a number of trials. For example, Dr. Majid told us about the GMMG result and also UMRO's trial which study VRD plus or minus isatuximab going to start, as well as ENN, in which carfilzomib, Revlimid, dexamethasone plus or minus isatuximab. In IKEMA, carfilzomib in combination with dexa, with or without isatuximab in relapsed refractory patient who underwent 1 to 3 prior regimens, and I'm going to elaborate on that study in more details later on. Icaria, in which the pomalidomide in combination with dexamethasone plus or minus isatuximab in relapsed and refractory for those patients who had equal or more than 2 prior regimens. Both Icaria and IKEMA met their primary endpoints of significantly improving progression-free survival in relapsed refractory multiple myeloma with the addition of isatuximab. As Dr. Majid told us about, GMMG also met the first primary endpoint of significantly improving minimal residual disease negativity after induction in newly diagnosed multiple myeloma. What is IKEMA? IKEMA is a study, it is a randomized study, phase 3, open label, study comparing isatuximab with carfilzomib and dexamethasone versus carfilzomib dexamethasone in patients with relapsed multiple myeloma. The number of the patients enrolled in that study, 302, and this is the stratification factors as you can see in the slide. And the randomization was 3-to-1 isatuximab carfilzomib dexa versus carfilzomib dexa, and they will continue on treatment till disease progression, unacceptable toxicities, or patient withdrawal. Of course, as you can see from the slide, the key eligibility criteria, key exclusion criteria. The primary endpoints in this study is progression-free survival. Secondary endpoints, as you can see in the slide. What about the schedule of the treatment in this trial or this study? We can see that cycle 1 isatuximab 10 milligram per kg on day 1, day 8, day 15, day 21, and this is the cycle 1. While carfilzomib will be, the first dose will be 20 milligram per meter square, day 1 and day 2, and the subsequent doses will be 56 milligram per meter square. Dexamethasone is the standard dose, 40 milligram weekly. When it comes to subsequent cycles, 28-day cycle, only isatuximab will be given 10 milligram per kg, day 1 and day 15. That's mean 2 times per 28 days, 2 times, while the carfilzomib will be kept the same, as well as the dexamethasone. From that study, patient enrolled reflect the real-world relapse myeloma patient population. As you can see here, the age, the median is really 65, comparing to both arms, 65 and 63, almost equal. A patient with equal or more 75 years, there are 9 versus 8. And if you look also to high cytogenetic risk at baseline, 23 to 25, it is almost equal. Median number of prior line therapies, 1 to 2. Prior proteasome inhibitor, as well as prior IMiDs, more or less the same. Refractory status. Lenalidomide refractory is 32 in ISA KD and 34 in KD. It is almost equal. So it is comparable, really, even in high-risk patients. IKEMA, the first interim progression-free survival analysis, demonstrated a 47% reduction of risk of progression or death with the ISA carfilzomib-Dixa combination versus carfilzomib-Dixa. And you can see here the blue line reflecting ESA KD with median progression-free survival not reached when they looked at the 2 years, and the hazard ratio is really 0.53 with highly significant p-value. KD showing median progression-free survival only 19.15. With a progression-free survival probability at 24 months, 68.9 in the ESA arm comparing to the other arm, 45.7. The improvement in the progression-free survival was consistent by pre-specified subgroups. The median time to next treatment was not reached. So, what about updated progression-free survival? This is the primary endpoint with intention to treat. You can see there is a significant difference between the two curves. The blue one reflecting isatuximab, carfilzomib-Dixa, and the red, the other arm with carfilzomib-Dixa, with really median progression-free survival 35.7 months, and the other one 19.2. With 2 additional years of follow-up, isatuximab, carfilzomib-Dixa showed the longest progression-free survival on a PI-based backbone in the relapsed multiple myeloma setting, with 42% reduction versus KD in the risk of progression or death. So, looking at the updated progression-free survival subgroup analysis, so all going to be in favor in the line of or in the arm of isatuximab KD, whether it is age or baseline renal function test or disease stage or cytogenetic analysis, as well as refractory to lenalidomide. So consistent benefit was observed with ESA KD versus KD across subgroups. This is the depth of response comparing the 2 arms together. Best overall response ESA KD, the blue color, KD, the red color, with an overall response rate or very good partial remission or stringent complete remission. But more important, if you can look here about the MRD negativity rate using next generation sequencing 10 to or -5, we can see minimal residual disease negativity is in 33.5% in the ESA arm, comparing to the other arm only 15.4. It is almost double. And when they looked at the minimal residual disease negativity and CR patients, they found that it is 26 in the ESA KD arm comparing to 12.2, more than double really. So deeper responses were seen with ESA KD versus KD. Minimal residual disease negativity rate with ESA KD in the intention to treat population was 33.5%, and minimal residual disease negativity and CR rate with ESA KD in the intention to treat population was 26.3. So what about progression-free survival, number 2? With and look at the blue curve here, ESA KD comparing to KD, it is superior, in fact. So ESA KD showing median progression-free survival 47 months, while in KD 35.6 months. So the benefit of ESA KD over KD was maintained late through progression-free survival number 2. Updated overall survival intention to treat population, showing also superiority of the ESA KD. And look carefully about the death events. Really, it is 35 in ESA KD versus 43 in KD. About survival probability, showing that at 36 months In the EHA KD arm, it is 68.7, while in the KD, 62.9. At 42 months, it's really more better, 66.3 versus 54.5. So favorable survival probability at 36 and 42 months observed for the EHA KDR. Final overall survival plan 3 years after interim progression-free survival analysis. What about safety? Despite more grade equal or 3 adverse events, addition of rituximab to KD did not increase mortality, serious adverse events, or events leading to discontinuation, as you can see from this table. So the high relative dose intensity in the EHA KDR and longer median duration of treatment exposure versus the KDR demonstrate the feasibility of the combination. Also here about EHA KD had a manageable safety profile with no safety signals. Infusion reactions mainly occurred during the first infusion and were mostly grade 1 to 2. You can see here, it is really 46%, but all grades, but grade 3 and more only 0.6. So infusion reactions mainly occurred during the first 2 days of study treatment. All infusion reactions were grade 1 to 2, except for one patient, isatuximab group, with carfilzomib-induced grade 3 infusion-related reactions. Most infusion reactions were reversible. Only one patient discontinued isatuximab due to infusion reaction, less than 1%, in fact. In conclusion about this, these results show unprecedented median progression-free survival, CR rate, minimal residual disease, and CR rate in a non-lenalidomide regimen with benefit maintained through subsequent therapies and manageable safety profile. So their findings support EHA KD as a standard of care treatment for relapsed multiple myeloma. Thank you for your attention, and the floor is open for any questions or opinion.
Thank you, Dr. Fahad, for this excellent elaboration. And so we come to the Q&A session and the panel to Dr. Majid. Dr. Majid, I mean, every year we're looking to hear that with the new novel agent that we are seeing, that we will hear that transplant is not anymore an option, or we can delay the transplant. But again and again, we hear data about most of the data in the last EHA meeting was talking about the option of transplant as upfront still remain the best. So what's your comment on that? Yeah. And will you be still favoring transplant or
Dr. Amal, I can't hear you. I'm not sure. Is it a problem from my side or your side? But I could not hear.
Hello?
I could not hear the question very properly. I'm not sure. Was it from my side or your side? But what I was able to understand that, you know, based on the current evidence, do we think transplant is still recommended or not? So now we have to look at what regimen were used in all of these trials, either the IFM-09 or determination. So it did not include monoclonal antibody as upfront. So for now, as per the current evidence, VRD with transplant would provide better PFS than VRD alone. Okay. So, and no one can answer clearly and for sure with the addition of monoclonal antibody, are we going to get rid of transplant or not? Because this is still a research question, and the Perseus trial will help in determining this in a better way, because they also randomize the patient transplant versus no transplant. But so it might be that might be the answer. So maybe with the addition of monoclonal antibody, we do not need to transplant everyone, but no one would be able to answer this for sure. But more data and more time will tell us more about that. But as I mentioned, for the current time, as long as we are using VRD as an induction, transplant is recommended.
Thank you. I think, yes, it's not, I mean, for now, I think we will, according to the data, it is the preferred regimen for now is to go hit hard from the start and then to go for a transplant. There's one question about what's your preferred maintenance and how you select that? And for how long?
Okay, so that's for me, I guess, or for the
No, yes, for you.
Okay. Well, it's not my preferred. We go by evidence. So now, if you look at all guidelines, the recommended maintenance is lenalidomide. Okay, addition of monoclonal antibody and all of that. Still, it's a research question, and it might be the future, but for now, as long as the patient not on any clinical trial, okay, as per what we have now in terms of guidelines, lenalidomide is the preferred maintenance. Other options, okay, is Velcade, okay, and this is for either patient could not tolerate lenalidomide, for high-risk patient possibly, okay, double maintenance, so len, Velcade, or bortezomib. It's also recommended, and it's not a must, I have to say, but it can be used and provide a better PFS in high-risk patients. So double maintenance can be considered for patients who are 17P, 1Q, translocation 414. So Velcade, bortezomib. For how long? Also, that's not clearly no one can clearly and surely answer this. There is a huge debate about that. But if you are saying, I want to use len until disease progression, no one will fault you, okay?
Do you have any comment, Dr. Fahad?
I think I do. I do agree with Dr. Majid for what he explained. However, the trend nowadays actually to give maintenance with lenalidomide, as Dr. Majid explained, until either disease progression or intolerance. Otherwise, if the patient tolerating the drug and there is no side effects, it should be continued until disease progression. Yes, somebody might argue with the cost. Lenalidomide is not cheap drug. This is relatively expensive. But if we shall put the benefit versus other side, I think I would prefer my patient to go for lenalidomide until disease of progression or side effects. And this is what we are going to apply in our patient actually nowadays, to give them lenalidomide as long as they are tolerating it and no side effects.
Yeah, thank you, Dr. Fahad. Question to Dr. Fahad, how you select your salvage for the first relapse, and how you select your monoclonals, since we have more difficult now with more options, our life become more difficult and complex. you comment.
Yes, thank you, Dr. Amel, for this difficult question. But however, I think we can try to answer it to some extent. In fact, even though we are using monoclonal antibodies in combination with proteasome inhibitor, second generation proteasome inhibitor, or other options, including the new treatment like selinexor or for example, belamaf, all these medications really has side effects and so on. And I think I do prefer really to give the patient really monoclonal antibodies in combination with a proteasome inhibitor and dexamethasone in case of lenalidomide refractory. Otherwise, I will choose other combination. But the question, the more question here really is that still this is not curable. This is not going to keep the patient on remission for a long time. So in my opinion, I think it is not the final answer. We have to wait for more studies and more follow-up and more maintenance therapy or just to continue the same treatment or the salvage treatment after that until disease progression. Probably, as we heard from EHA nowadays, just last 2 weeks, when cell results came up and we heard really that it is giving more response, more duration of response, and still we have to have more time to wait for the final result. I think still multiple myeloma is a very difficult disease to be treated. However, alhamdulillah, we are successful nowadays. We are changing the multiple myeloma into chronic relapsing disease. Nowadays, even though we are speaking about relapse refractory, lenalidomide refractory, and so on, but we are seeing at least 20% of the patients who are treated with induction and auto-transplantation, they can survive for more than 10 years. And this is really leading me to one opinion that multiple myeloma is not one disease. I think, in my opinion, it is multiple diseases, heterogeneous diseases. We are treating and we are saying that the best induction treatment to start with VRD and autologous stem cell transplantation, followed by maintenance lenalidomide. Nowadays, we are moving towards adding monoclonal antibodies. I don't know what the future going to tell us about these things, but probably we have to have a new, new guidelines for those patients who are newly diagnosed to stratify them, whether they are going to have really simple treatment like PRD, transplantation, and they might go and maintenance, and they might live for 10 years or more, and that will be good, or to add monoclonal antibodies to certain patients, certain group patients, and that can help them to give them more response, more deep response, and so on. So it is a very difficult nowadays. Still, we need more time, and still, multiple myeloma is an incurable disease. Thank you.
Thank you, Dr. Fahd. Question on tandem transplant, your opinion? Anyone would like to answer?
Okay, because
okay,
Dr. Majid, go ahead.
No, go ahead, Dr. Fahd.
لا انت اللي you start newly diagnosed. Please go ahead.
So as per the stamina trial, so for high risk patients, still it showed an advantage. And I've showed you two protocols for two different trials using a quadruplet. One of them actually, as part of their protocol, they included the tandem transplant, the French one. And I think that because in Europe, they use more tandem transplant for example, if you go to Italy, for example, they believe that tandem transplant should be considered for most of the patients. In France, the IFM, they believe it is the way to go for high-risk patients. Where if you go to, for example, the Mayo Clinic recommendation, it's an option, okay? So for high-risk patient, okay, young and fit, it should be considered, okay? And it has to be discussed with the patients. And during the collection, we have, especially for high risk, 17P, 1Q, translocation 414. As upfront, we have to collect for 2 transplant, and we have to push as much as possible to go for tandem to manage that group patient. Would that be the ultimate answer? Maybe things will show us something different, especially with improvement of our induction techniques with incorporation of monoclonal antibody. Okay, now there is a different novel approach for these patients, which is using CAR T-cell right in the upfront. Okay, so you know, looking at the MRD status for the patient after the first transplant, if they are still MRD positive, to consider as a research question. This is still a research question, I'm saying. CAR T-cell as a tandem after the first transplant. But as I mentioned, as per now, for high-risk patients, 17P, 1Q, translocation 414, tandem transplant should be considered.
Dr. Fahad, you want to elaborate more also, or
I think I will tell you about our practice at King Faisal Specialist Hospital. We still in favor to do the double transplantation or tandem transplantation in those patients with high-risk disease, really. However, nowadays we are thinking to add monoclonal antibodies to our regimen VRD, but still I think I will push for tandem transplantation for those high-risk patients.
I think since we have like 2 different trials looking at almost the same study, same group of patients, both are high risk, the French trial and the German trial, one of them tandem transplant, the second one single transplant. I think the long-term results of this trial will help us in answering that question. So with addition monoclonal antibody eliminate the need for tandem transplant in that group of patients or not? Still early to make a conclusion. It has been only 2 years follow-up. As I mentioned, the results were encouraging. Overall response of more than 95%. The PFS until now after 2 years is very great, but we need more time to see the results. But I think these 2 trials, the IFM 18 and the German trial for the EHA VRD will help in answering and give us more directions.
Okay, Dr. Majid, I do agree with you, really. We have to wait for the result of the trials and so on. But I would like just to ask a question. What we are doing nowadays for our patients?
For now, I think as I mentioned, we have to consider tandem transplant for high-risk patients.
Thank you.
One last question, probably will take the role of CAR T-cell in relapse refractory setting for Dr. Fahad.
CAR T-cell? CAR T cell now, actually, the problem with it really, it cannot be used in those patients who are relapsed early after 1 or 2 or 3. The criteria has to be after 4 lines or more treatment. Yes, I do agree. Nowadays, there are new studies, Cartitude, I think 5 or 6, 5, I think 5. They are enrolling patients, newly diagnosed multiple patients, to be treated with CAR T therapy early in their treatment. I think that is going to tell us really in the future what we are doing. But right now, without trials, nobody will think about CAR T cell in patient with less than 4 lines of treatment.
But do you think this is
Okay.
the best way, Dr. Fahad? You know, as the time goes, these T cells become exhausted, and the efficacy of the CAR T cell might not be the best in those terminal patients. You know, maybe the answer would be use of off-shelf allogenic CAR T cell for that group of patients, because the T cells will be more effective in healthy donors rather than using an O2 T cells, which is quite exhausted because of the disease itself, and also multiple lines which are affecting the T cells function for sure.
I can agree partially with this philosophy, but you know about allogenic stem cell transplantation. We have an experience, good experience about allogenic stem cell transplantation.
No, I'm saying allogenic CAR T cell. Now there is the off-shelf.
Sorry,
Yeah.
sorry.
No,
I thought about allogenic.
No,
allogenic.
Yeah.
Yes, I think CAR T cell is still in the early phases, and we have to wait for more result. However, cilta-cel, as I mentioned, really last updated about Cartitude study showing really a good promise and a good future, because the response is increasing and it becomes durable. Nowadays, we are speaking about 2 years durability. And I think by the time we can improve the CAR T cell and to find out where are the caveat of the CAR T cell and to correct it, and probably that going to help us in the future for a better treatment of our patient. Wallahu alam.
Yeah, I think we need more experience with the CAR T cell in this area. Okay, we come to the end of our webinar. We are on time. At the end of the session, I would like to thank our speaker. Really, we've been enriched with all the information that's been presented. Especially, it's all fresh and just updated through the EHA, which is last meeting last week. And there are a lot of updates and informations. Thank you, Dr. Majid. Thank you, Dr. Fahad, for the excellent presentations and answering all the questions. There are some more, inshallah, we could submit some answer for that. Thanks for our attendees, which reached more than 900 attendance to this webinar. I would like to thank Sanofi again for the sponsoring of this webinar. And again, you can reach to this and hear the lectures again through our channels and YouTube channels for the SSPD. And again, the webinar is CME accredited. And we'd like you to invite you for the next week webinar, which will be, inshallah, about the update on the CML. Thanks for your time and have a good night.
Thank you.
Thank you very much for everybody, and assalamu alaikum wa rahmatullah.
Okay, bye-bye. Thank you.